All right. So this is Justine Sparrgrove for pharmacology. We are on Learning Plan 2, pharmacology and the nurse-client relationship. You will see a lot of what we cover in this podcast was either touched on in Learning Plan 1 or what was part of Learning Plan 1 is being touched on more in Learning Plan 2 here, okay? So I just thought I would let you know. All right, so the nursing process. Note there are 5 steps in the nursing process: assessment, diagnosis, planning, implementation, and evaluation, also known as ADPI. This is covered in Chapter 6 more extensively. You will also talk about this in fundamentals if you haven't already had it, and this will continue on with you for the rest of your nursing career. So we'll go through this every day with every encounter for each patient. We will continue to come up and it will continue to come up and you'll eventually utilize this without even realizing you're doing it. So make sure you look at Table 6.1 for questions that relate to the assessment phase of the nursing process, and Table 6.2 for the NANDA approved nursing diagnosis relating to the drug administration that you may see used. So here is a picture out of our book, Chapter 6, that shows the nursing process. First is assessment. So we collect data, organize data, validate data, and document data. This can be subjective or objective. This includes history, H&P, labs. Next is diagnosis. So we analyze data, identify health problems, including risks and strengths, and formulate diagnostic statements. And these are completely different than medical diagnosis. So you do have a Sparks and Taylor nursing diagnosis book that you were asked to purchase. This has long lists of nursing diagnosis that we use. So for an example, Alzheimer's disease, they have anxiety related to situational crisis. So that can be a nursing diagnosis. You wouldn't just say Alzheimer's disease. Another one, alcohol addiction and abuse. They can have acute confusion, or they can have coping, defensive, related to perceived threat to a positive self regard. So these are, again, nursing diagnosis. We cannot use a medical diagnosis, okay? Next is planning or prioritizing. We formulate goals and outcomes, select nursing interventions, rate nursing interventions. Then it comes implementing. So we reassess the client, determine the nurse's need for assistance, implement the nursing interventions, supervise any delegated care to another healthcare professional, and document those nursing activities. And then finally, we evaluate. So we collect that data related to the outcomes. We compare data that we achieved with the outcomes. We relate nursing actions to the client goals or outcomes. We draw conclusions about the problem status. So then we either continue, modify, or we terminate the client's care plan. And then we start all over again with assessing. So NCLEX style question: which method may offer the best opportunity for patient teaching? So 1, provide detailed written information when the client is discharged. 2, providing the patient with internet links to conduct research on drugs. 3, referring the patient to external healthcare groups that provide education, such as American Heart Association. And 4, providing education about the patient's medications each time the nurse administers drugs. So I want you to take a second and look at these. All right. So if you look at all 4 of these, you could say any of them could be true. But what you need to do is look at the question. What is the question actually asking? It's asking for the best opportunity for patient teaching. So by sending home written information, how do we know that they actually understand it or even read it? We don't. So that one's out. Sending home some internet links, we're asking them to find the information themselves, and then they have no one to ask questions to if they have some. We also don't know where they're getting their information from. Is it a reputable site? We don't know that. Referring them to the American Heart Association is just like sending them to look on the internet. So that one's out. So our best answer is providing education every time you give the drugs, and you give the patient the opportunity to ask questions and clarify and get that personalized care, okay? 10 rates of medication administration. So we did touch on this already a little bit. So the top 5 need to be done each and every time and needs to be done 3 times total before you give a medication. So the other 5 are good to include. I will say that right documentation, which is spelled wrong, sorry, I will fix that right away, should be every time. I mean, no matter what you do, you have to document that you gave that medication. So really that one kind of slides in with those 5 to kind of make it 6. So again, the documentation, you always have to document that you gave it, whether you're signing off or clicking yes, you gave it. It's some sort of documentation. The right to refuse includes informed consent. So you tell the patient, hi, my name's Justine. I'm going to give you your medication today. And they respond, okay. That's an informed consent. Okay. Right assessment. Did you check the patient's vitals before giving them that blood pressure med, that metoprolol that we talked about? Or did you just give it without checking their heart rate or blood pressure? And was their blood pressure too low? You know, maybe their blood pressure was low and you didn't know it and you gave it and now it's really low. So make sure you have the right assessment every time. Right attitude. Are you walking in, stomping your feet, looking at the ground, not saying anything to the patient? Or are you coming in with a friendly, positive smile? So always make sure that your attitude is positive. Patients pick up on things like that. And, you know, when you don't feel good, you want someone around you that's positive, not someone who's grumpy anyway. Right technique. So when you give something IV or IM or any other form, make sure that you're using that right technique that goes along with that. And again, the right documentation. Did you provide the right documentation as soon as you gave the medication? So you will always be doing that. Medication orders. So some routine orders that you'll see is STAT, which means immediately. It's usually only given once, and it's usually an emergency situation. The time between writing the order and administering the drug should be no more than 5 minutes, okay? There are things that do happen where maybe the physician writes a STAT order but doesn't communicate that to you, so then it's got to go through a whole process of going through the pharmacist, or you may not see it within those 5 minutes. But ideally, and in that perfect NCLEX world, you will have that order, you will know, you communicate with the physician, and you will give it within 5 minutes or less. ASAP, as soon as possible, should be available for administration to the patient within 30 minutes of the written order. Now means within the hour, usually. And PRN as needed. So PRN Q6 means that if I'm having pain, you give me Tylenol, that's great. And if in 6 hours I feel I need it again, then you can give it to me again. Otherwise, in 6 hours, if I feel fine, you don't have to give it. It's just as needed. It's not scheduled. Standing orders and protocols. They're written in advance of a situation. So like a standing order may be oxygen, 2 liters per nasal cannula of O2 stats drop below 89%. That would be something that's there that if you need it, you have it. A protocol, maybe like a diabetic protocol. So if blood sugar drops below 60, the protocol will tell you, okay, your blood sugar drops below 60. You know, next you need to, you know, maybe give them some sugar substance, whether it's orange juice. Make sure you give them a carb. Check the blood sugar within 15 minutes. If it's below this, do this. You know, give them D5, da 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 da. It tells you exactly what you need to do. Okay, so make sure you know where those are and who to talk to if you don't. Some abbreviations. You need to be familiar with these. You will see these over and over again, so you are expected to know these. They are in Chapter 3, so please, 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 please look at these. This next section as well is in Chapter 3. You also need to know these. These are common metrics, and you need to know how to convert these back and forth. We will have some math on every exam, so please make sure that you brush up on that, whether you need to see Pete or John to brush up on that, or just pull out your medication calculation book and just work on some of that. Routes of medication administration. So make sure you understand the different routes. So PO means oral, SQ means subcutaneous or into the fatty tissue, ID is intradermal or under the skin, IM is intramuscular into the muscle, IV is intravenous into the vein, TOP or top is topical. It could be a salve or patch. PR is per rectum or usually known as suppository. SL is sublingual or under the tongue. Epidural is into the spinal fluid. Buccal is into the cheek. And intravaginal is inside the vagina. NCLEX style question. Which of the following medications would not be administered through an NG tube, a nasogastric tube? And select all that apply. So liquids, enteric-coated tablets, sustained release tablets, finely crushed tablets, or IV medications. Take a moment and look at those. All right, so liquids. Yes, we can administer liquids through an NG tube. Enteric-coated tablets. No way. They're coated for a reason. So it's not able to be dissolved into the stomach and cause ulcers. It's made so it bypasses and it doesn't dissolve until it hits the intestine. So there's a reason why they're enteric-coated. Sustained release tablets. Sustained release. Release means slowly release, so that maybe in 12 hours and maybe in 24 hours, whatever it is. So if we take them out of the capsule, then they're going to be released right away. And it's one of those things, just like the enteric-coated, that they're made that way. Finely crushed tablets, yes, we can use finely crushed tablets, as long as they obviously are not enteric-coated or the manufacturer says otherwise. IV medications, no. Only oral medications are to be given NG tube. IV is only for the IV. Adverse drug effects. We did cover some of these in the last learning plan. So the adverse drug effects, the side effects would not be tolerated well by the patient. And every med will have different side effects. Idiosyncratic reactions are those strange off the wall type of reactions. Anaphylaxis, we talked about, like a bee sting, could have chest pain, throat closes, can be very dangerous. Tetragenic drugs are have detrimental effects on fetuses, so they are not good for the fetus. They could even kill it. Drug tolerance is a buildup of the medication to the body. It's almost like it not completely becomes immune, but in a way becomes immune. That's where they build up that tolerance. Drug dependence, you may become dependent, so you may feel that you have to have that, like almost like you can't live without it, or you need it to continue on. Medication safety. So, question. If the patient refuses the medication, what is the nurse's responsibility? It would be the nurse's responsibility to document the refusal. Okay, very first thing you do, document. Again, if you don't document, it didn't happen. So wait an hour and try again. Or send another nurse. If it's someone that's got dementia, sometimes it's just giving that time in between or introducing a new face to them, and they will take it for the other nurse. If the medication is something that's necessary, we may need to call a physician and find out what they'd like us to do. And remember, you can never force a medication on a patient. They have rights, and they have the right to refuse. If a medication error occurs, what is the nurse's first responsibility? Use the first step of the nursing process, assess them, okay? Then call the physician. If you call the physician without assessing them and they ask how the patient is, what's their vitals, how are they acting, and you have no idea, have none of that information, the physician may be a little furious with you. And it will make you look incompetent. You have lots of education behind you, so show it. A lot of places use the SBAR, which is a tool that they use to make sure that they have all the information they need before they call the physician. Next, you need to fill out an incident report. Let the facility know that it occurred. So make sure that it doesn't happen again. You don't want to, accidentally do something and, it caused harm. But even if it didn't cause harm, you don't want it to happen again and potentially cause harm the next time it happens. What are the ways that you as a nursing student will identify that you have the correct patient? Even if you're not a nursing student, what's the best way to correctly identify your patients? Use two-person identifiers, name, first and last, and date of birth. Look at the wristband to make sure that you have the correct patient as well. Some places do have pictures, so you can use pictures to identify patients as well. What should the nurse do if he or she is unsure of the physician's order? Call the physician, okay? You could talk to the pharmacist, but the best bet is to check with the person who wrote it. They know exactly what it says. The pharmacist may have an idea of what they wanted, but again, they didn't write it, so they don't know 100% sure. And don't ever be scared to call the physician. The physician are people too, okay? So they're just like you and me. All right, what are the pregnancy categories and what does each of them mean for the patient, okay? So make sure you review categories A, B, C, D, and X. So A is A-okay, X is no way. So again, here are your pregnancy categories. So make sure you review them. We did already touch on them in the last learning plan. They are on chapter 2, table 2. So go ahead and look those up. What changes in the elderly may cause different reactions than with a younger person? We talked about the organs in the elderly are no longer working at their maximum capacity. So that may affect the metabolism and excretion involving their liver and their kidneys, right? So make sure that we're checking labs and always taking that into consideration. What does your patient have a responsibility to know? What medications they are taking and why? Oh, I said what does. Sorry, does your patient have a responsibility to know what medications they're taking and why? And how would you go about doing this if your answer is yes? So yes, it's important for them to know what medications they're taking, why they're taking it, and how they need to take it. They need to know what the common side effects are and if they could interact with other medications. They may not truly understand the effects of missing doses or decide not to take the medication because of the side effects. So maybe they're like, oh, this one makes me sick to my stomach, so I'm not going to take it. Well, maybe it's, one to thin their blood, or there's no such thing as thinning the blood, but changing the viscosity of the blood. And maybe they truly need to be taking it, to prevent having a heart attack or a stroke. But if they don't truly understand that, then they're not going to take it. So again, best thing you can do, educate. The medication is ordered to be given at 1100. How much time does the nurse have to give the medication? And give an example of facility policy and procedure that you're aware of in your workplace. So depending on the facility, you may have half an hour or an hour on either side. So if the med's due at 11 and you have a half hour leeway, one side or the other, you have from 10:30 to 11:30 to give that med. If you have an hour leeway on either side, you have from 10 o'clock to 12 o'clock to give that medication. So make sure you know what their policy is. And if you don't know, just ask. They'll be happy to tell you. If the medication says morning, lunch, dinner, bedtime, you have more of a leeway. And you usually only see this in long term. So if the medication says morning, you have all morning to give it. There's nothing specific saying that it's at 9 o'clock to be given. The facility may automatically generate like a 9 a.m. time stamp, but it's not truly set to be given specifically on that time. Same thing with, like bedtime. So if it says bedtime, but your paper says 8 p.m., that may just be a time that automatically gets generated, but you have until the time the patient goes to bed or says they're going to bed to give it. And again, make sure you understand the policy and procedures within the workplace and where they are, and make sure that you ask if you don't know. Never be scared to ask. That's how you get yourself into trouble. What are some important issues to consider when administering narcotic medication? And when is the narcotic count usually done? So, double lock and key, right, for important issues to consider. Wasting needs to be done with 2 people, 2 licensed professionals, preferably. Know how and where it needs to be wasted, and make sure you're documenting appropriately, okay, because it always needs to be documented somehow. The narcotic count is usually done at change of shift. And if you're using a Pyxis or an Omnicell of some sort of machine, it will do it continuously when the medication is pulled. Explain the drug schedules and give an example of a medication that belongs in each category. So the first one would be heroin, marijuana. Second schedule, Vicodin, morphine. Third, anabolic steroids, anything containing less than 15 milligrams of hydrocodone or no more than 90 milligrams of codeine per dosage. Schedule 4, benzodiazepines or anything that ends in PAM. And 5 is cough medicines that have codeine. So make sure you brush up on that and know which medications are in which schedule. What are some of the most prevalent reasons for medication errors occurring in the workplace? it's almost always a system error. It sometimes can be human error, but usually it's because you're bypassing the things that are set up to protect you and your patients. So never do that. Again, there's reasons why they're there. It's not just to get underneath your skin or take up your time. It's for safety usually, to keep you and your patients safe. Explain the process of pharmacokinetics and pharmacodynamics. So pharmacokinetics is, again, right, kinetics, movement. So make sure you remember the ADME, assess, diagnose. No, sorry. Good Lord, I can't even think. I'm drawing a blank. Sorry, guys. ADME, metabolic, excrete. Okay. Anyway, dynamics, onset, peak, and duration. Make sure that you know those, okay? Throughout the lifespan, what are some implications to take into account when dosing infant, toddler, pediatric, adult, and geriatric clients? What are some implications? So let's think about that. We need to make sure that we take a look into the different lifespans. So infants will need smaller doses, obviously, right? They're smaller. We need to look at children and trusting. So if you ask a 2-year-old or even a 5-year-old, do you want to take this med? They're going to say no, right? So we don't, just ask them. And we can draw up the medication, double check it with another nurse, and give it to the parent. Stay in the room and give it to the parent, and the parent can give it to them because they trust the parent, right? Or whoever the person is that's with them. We always want to make sure that we're double checking pediatric doses just for safety. They are smaller, and so a lot of things are a little bit different with them. So we want to just take the extra safety. And the geriatric, we look out for that toxicity. So always look at labs. All right, a nurse is administering a liquid medication to a 15-month-old child. What is the most appropriate approach to medication administration by the nurse? So 1, tell the child that the medication tastes like candy. 2, mix the medications in 8 ounces of orange juice. 3, ask the child if she would like to take her medication now. 4, sit the child up, hold the medicine cup to her lips, and kindly instruct her to drink. And 5, offer the child a choice of cup in which to take the medicine. So answers 4 and 5 are the correct ones. We can't do 1 because it's lying. 2, we can mix it in 8 ounces, but for a child to drink the 8 ounces is pretty unlikely. And once we put it in there, it's diluted throughout, so they have to drink the whole 8 ounces. Ask the child if they want to take it, but like I said, they'll usually say no. And then giving them a choice lets them have control. So that's why we want to give them a choice. And if you give them the medicine cup and stuff and we instruct them to drink it, they feel like they have a little bit of control over that as well. So nursing responsibilities. Your responsibility, so know your role. So use the nursing process, so the ADPI every time. Utilize the 10 rates of medication administration, and you must utilize the first 5 and do that 3 times over. Know the agency's policies and procedures. Know the Nurse Practice Act. Know the Code of Ethics and follow them. And do no harm. To do no harm. So you have to know that what the harm is before you can not do harm, basically, okay? Cultural implications. Know the culture you're working with. Set of beliefs, values, and norms that provide meaning for the individual or group. Look at dietary considerations, so spices, herbs, interactions, certain food interactions. Look at the alternative therapies, so like Chinese, for example, they use herbalists. Hispanic culture looks at spices and herbs, hot and cold, yin and yang. Beliefs about healthcare and diseases. So the Native Americans consult in a tribal leader. Hispanics consult in a fold leader. And African Americans, they like to lay on their hands. Okay, so just knowing these. So make sure that you brush up on things, know a little bit about stuff. And if you don't and you happen to take care of somebody, make sure you educate yourself. Okay. The client informs the nurse that she will decide whether she will accept treatment after she prays with her family minister. What role of spirituality in drug therapy? What is the role of spirituality in drug therapy for this client? 1, irrelevant because medications act on scientific principles. 2, important to the client's acceptance of medication treatment or medical treatment in response to treatment. 3, harmless if it makes the client feel better. 4, harmful, especially if treatment is delayed. So the best answer is 2. If it's important to the client's acceptance of medical treatment in response to the treatment, then it's A-okay. All right, so terminology. So make sure that you look at these. Cultural competence, psychosocial, polypharmacy, which is the abundance of medications, CAM, or complementary and alternative medications, and tetragen, which can cause harm to the fetus. Okay, so that is all that I have for this learning plan. So again, if you have questions or things, let me know, and I'd be more than happy to go through them with you. Otherwise, I will see you in class.